Next speaker, Dr. Saurabh Shah. You can share your video. He's a consultant ophthalmologist, phaco-refractive surgeon, a very young and dynamic person from Prisa Eye Hospitals, and he has a wonderful video to show us. On to you, Dr. Saurabh.
Thank you, ma'am. Thank you so much. And thank you so much, everyone. It's good to see you in this Sunday afternoon. And I'm sharing my video. It has its own voice. So here is the... Okay. Hello friends, I am Dr. Saurabh Shah, consultant eye surgeon, and today I am going to talk about key factors to success in high myopic cataract surgery. As we all know that high myopic cataract surgery will come with certain challenges. So intraoperative planning is as important as preoperative workup. So the first challenge is to select the correct IOL power. You can see we are dealing with 29.5 mm of axial length with a deep MTA chamber of 3.5 mm. Here I prefer IOL master data and SRKT as well as Barrett universal formula for IOL calculation. I tend to go a little bit myopic from 0.5 to -1 diopter for IOL power. This surgery is done under the topical anesthesia. This is 52 years old male patient with nuclear cataract and posterior subcapsular cataract. Surgery is not going to be difficult or different, but to avoid any surprises, we must do some things differently. So the first difference is to change the angle of side port entry. When I am dealing with the deep anterior chamber, I make the side port entry near the limbus and direction towards the center of anterior capsule. Usually, what we do is we take the side port incision directed towards the angle of opposite side, like the first image. But when we are dealing with the deep anterior chamber, I take the side port entry facing towards the center of anterior capsule and thus changing the angle of entry. Let's see side-by-side videos of two different angles of entry, and let me show you how changing of an angle can make a huge difference in your surgery. In the right side video, you can see that I am facing difficulties creating CCC, even my movements are restricted, and you can see the corneal distortion at the entry point. But in the left side video, with the new angle of entry, you can see every step is so easy to perform. The basic idea of changing this angle is that all the instruments that we are using in the cataract surgery like chopper, IOL dialer or bimanual irrigation aspiration cannula, all that are working in the direction towards the center of cataract. The another important aspect is to create the perfect size of CCC with the proper centration. Various methods available like capsular marking ring, marked forceps, or even you have liberty to use Alcon variant image guided system. It's good, but if you don't have anything, don't worry. You can just use your mental marker. Just remember one thing, that at any given point or at any magnification, your main port entry size will be remain the same, like 2.2 mm. So just create the mental marking of this main port entry and start making the neck from the center. Create a little bit larger neck than that and start doing the CCC. And the end result is amazing. You can see the approximately 5.5 mm of the size with the proper centration. Friends, well begin is half done. With this, we are good to go with the normal phaco surgery. You can see I am doing the normal phaco surgery with stop and chop technique. Just mark one thing, that I literally have to dive in for all the maneuvers, but there are little distortion of main port or side port entries. So the movements are very easy and the surgery is easy to perform. One thing that we have to remember is reverse pupillary block or lens iris diaphragm retropulsion syndrome. So what are the signs? The first sign is sudden deepening of anterior chamber as irrigation enters the eye, and patient suddenly start complaining of pain, pressure or discomfort during the surgery. Just remember, never enter the eye with irrigation on, operate on low perfusion pressure, and if such thing happens, just lift the iris with your second instrument and fix the pupillary block, and you can perform your surgery in a normal fashion. So I have completed the bimanual irrigation aspiration, and now it's time to implant the intraocular lens. Here I am only using the irrigation and not using the visco, and the IOL is implanted in the bank very easily. With that, side ports are hydrated and surgery is done. The end result is amazing. The side ports are sealed immediately with just a single hydration, as there is very less manipulation and distortion of a wound. The second eye is posted after the few weeks. This is the post-operative refraction reading, and we are glad that we bang on target, and of course the patient is also thrilled because he said he had never seen anything like this in his entire life. After 1 month, detailed refraction and retina examination is done and patient is doing well. So here is the 4 most important points that you have to remember for high myopic cataract surgery. Thank you.
Wonderful surgery, lot of tips and a lot of buzz. So of course, that idea of going right to the center of the capsule and not directing. Maybe we don't think of that particular step, but that was good. But more importantly, certain questions when we are talking about doing, you said the Barrett's formula. So I just wanted to bring home an important factor that the Barrett's formula also has now an IOL design factor incorporated in it for the effective lens position. So like even you initially from the biconvex to plano-convex to meniscus lenses. So if we have access to the Barrett formula, we can use the right IOL design factor also, which would be an extra added point to ensure that the effective lens position is bang on and we get the right emmetropia. Now, the other thing which I would want to ask the expert panel is, supposing these eyes were to have a PC plaque in a high myope, how would you think of handling these cases? Would you try to somehow remove the plaque on the table, or would you wait for 3 months to do a YAG, or would you want to know if there's PVD which has occurred before you do a YAG, or would you want to do a PC polishing? I want Dr. Ramurthy. Yes, Ragini.
Yeah.
Ragini wants to.
Okay, Ragini.
It is better not to disturb the PC during the primary surgery in myopic patients, because even after you have taken precautions and done a complete retinal examination, the anterior movement of the vitreous and the disturbance of the phase would lead to your problems and would increase the problems. These patients are 100% under topical anesthesia. You don't want to do these patients under block, because you do not know where the staphyloma is and how it is, and you don't want to puncture the globe. But one more observation I would like to make is that, these patients somehow or the other are extremely uncooperative, because probably, they can see what you are doing. And these are the patients who turn up a lot to us, where we don't do any PC tomies in our own patients, but these are the patients who turn up to us 1 year, 2 years later with needing PC polishing. So polishing the undersurface of the capsule is extremely important in these patients. And you have to deal with the PC plaque at a later date if it is really very big and it is going to obstruct the patient. But I have not come across patients with myopes with PC plaques unless they have a posterior polar cataract or something like that. And then at that time, I would polish it using an AC maintainer, but not to, at no time would I attempt a PCC.
I sort of agree with Ragini in the sense that most often, fortunately, we don't face this situation. And if at all, quite often you are pleasantly surprised that you on the table, you think there is a PC plaque, there's a PCO, but then the patient has reasonably good vision post-operatively, and it bothers the surgeon more than the patient, and we can just leave it aside. And maybe later on, a couple of years later, if PVD has occurred and then subsequently we do a YAG laser, it is quite safe. And all points very nicely emphasized, Dr. Saurabh, but maybe we just mentioned it in the passing. One of the things in these high myopes that I always do is to keep the IOP extremely low. I mean, this is one situation where I keep it at 20, which takes to a bottle height of about 31 centimeters. So if your machine doesn't have the ability to fix the IOP, reduce the bottle height to a minimal amount. And that makes most of these deepening of the anterior chamber, whether it's during the phaco steps or during IA, much better control. And of course, iris retropulsion, sometimes if it is repeatedly occurring and it keeps bothering you, then it's even a good idea to put a single iris hook and just tent up the iris in one area. And that way, there's always a constant communication between the behind the iris and in front, and it stops from occurring.
And if on a centurion, you should lessen your irrigation factor and keep it to 1 instead of higher, so that there's a more gradual buildup of IOP, so that the patient doesn't feel any pain during the procedure. Yeah. So I think
can I add one thing, Chitra?
Yes, all the time with the aspiration and the use of AC maintainers are very helpful in myopic patients. Saurabh sir, it was a beautiful presentation.
Very nice presentation, Saurabh.
Yes.
I think.
Thank you, sir. Thank you so
one of the things I want to add is with the dense PC plaque, it happens post silicone oil, and these patients sometimes when they have detachment, they are high myopes. Yeah. I do a plaquectomy. I just remove the plaque without damaging it's a bimanual technique, just like removing the ERM from the retina, we can do that as well. But it's a little difficult learning curve is there. Another important thing, all eye myopes, just like posterior polar cataract, please inject visco when you come out of the eye, because the shallowing of the chamber causes endophthalmodonosis. And every time there's an endophthalmodonosis, there can be a traction on the vitreous base. And these patients can develop postoperative retinal detachment. Of all these patients, after 2 weeks, dilate the patient, examine the periphery, because the cataract surgery itself would have induced a PVD, and peripheral retinal breaks can occur. All of a sudden, we end up in detachment in the retina postoperatively. This occurred to me. I have burnt my fingers so many times.
So why?
We do it 1 week, 1 month, 3 months. Retina examination, we normally do it 1 week, 1 month, and 3 months. And the second thing is that intracameral injection of.
Do you charge every time?
Up to 1 month, it's free, Ram. So there's no problem. And,
at the time of surgery itself, we charge.
Yeah, the charges are pretty good at the time of surgery. But the other thing is that intracameral oculon or phenogen, basically, if you're doing it under topical, because this reduces the pain sensation. Though it is all these points have been made, it's mainly the excess pressure. But then if you can put intracameral Xylocard or whatever, I think that helps a little bit more.
Now the last
intracameral is there, sir.
The last point on multifocal, this high myopsis, if you are going to have a multifocal IOL implanted, would you look at making the other eye myopic? If so, in a multifocal, but in a trifocal, would you look at emmetropia? Why would you want to make it 0.5 myopic? Are my questions.
No. The trifocal, all these lenses, if you are the decay is much worse if you are making the patient myopic. So whatever is being told is to keep it to the first hyperopia rather than a myopia. So if you are looking at a trifocal lens, your IOL power calculation should be accurate. And you should try to keep it not give a myopia, because the degradation in the quality of the vision is pretty significant. The blur is much more in a myopic residua than with emmetropia or a slight hyperopia.
And I would prefer a +4 lens. High myopes, always, because people are used to very good near vision. So I put a +4 lens in one eye, that is Technis +4. Then other eye I put a 3.25 or mixed and matched.
I think it's a misconception to say that high myopes are used to good near vision. That applies to -1, -2, -2.5. People with -14, -13 are not seeing well at any distance. So I would rather aim at emmetropia, as was being said.
Yeah.
No. I'm talking about emmetropia only.
Technic multifocal, you're saying.
He's saying Technis multifocal +4.
Is there any single piece lens that is available in minus power?
No. Minus power?
Yeah, because I only use all power sensor.
I think less than +5, it's not
available. 68.
Sorry?
Rainer.
But that will be hydrophilic, right? Is Rainer available in minus power?
They have a semi-hydrophobic lens now.
But that's available in minus power also?
Yeah, and I think Care Group also may have.
I don't think we have anybody, because Bausch & Lomb aspheric starts with +1 or +2, I think. But if we go on to -4, -5, normally I have to go on to a 3-piece lens. And the lens that I use is a Sensor odd power that we write. So I was just wanting to find out if there is a single piece lens that's available.
One point I would like
We shall now go